So everyone, in today's video, we've got another brilliant case study for you. This patient has knee pain. Can you work out what's going on? We're going to take you through the case, through the assessment, and through the diagnosis. So if you're ready to learn, let's dive in. Hey everyone, Khalid here. Welcome back to Clinical Physio. Today we've got another brilliant case study for you. This patient has knee pain. Let's start with the subjective history. So we have a 35-year-old male patient, and their key complaint today is right lateral knee pain. Now, they describe that their symptoms have been gradually worsening over the last 6 months. 6 months ago, they don't remember a particular injury, trauma, mechanism of injury that occurred, but they've been noticing it's been gradually getting worse over that time period. What we do know with this patient is that they have a history of issues on the same knee, on the same side. So this patient, aged 18, so 17 years ago, had a lateral meniscectomy, removal of part of the meniscus on that lateral side when they suffered a meniscal tear playing football. Now, from what we know, everything went well with the surgery, everything went well with the rehab, but it's important that we appreciate that this is part of our patient's past medical history, if you will. So he's not playing football nowadays, but we do know that his symptoms are quite irritable, and they can be irritable most of the time. He experiences nighttime pain, particularly when he's turning over in bed. He feels that his right knee gets painful. He also notices that his symptoms are there first thing in the morning. He feels a stiffness as well as pain first thing in the morning that eases around about 30 minutes later. We also know that his symptoms are aggravated by walking and going up and down the stairs and kneeling. When we're thinking about the walking, it doesn't take long. It could be 15 to 20 minutes before his symptoms start to get worse. Whilst this is all in the background, we know that there are no issues with locking or giving way, and therefore we're less worried about certain red flag conditions at the knee. So that's our patient's subjective history. Next, let's have a look at the objective examination. So here's the examination. First of all, we find that when we look at the patient's gait, it's clearly painful for them. They're not walking with any aids like any crutches, but it's clearly painful for the patient. He's walking with an antalgic gait, which is a gait which is either a shortened stride length or a reduced stance phase time because of the fact that it's painful for the patient. They're almost limping on that leg a little bit. And when we look at this particular patient, we can see that there's far less time in stance phase. They step onto their right foot and then they quickly want to get off it because it's painful to spend time in stance phase. We also can see that there's swelling around the knee, particularly on the lateral side when we observe the knee, and then that seems to be replicated when we palpate. When we're doing palpation, rather than one specific point being painful, you palpate along the lateral joint line as a whole, and quite a lot of the lateral joint line seems to be quite sore and irritable for this patient. So then we go through range of movement. We clear the hips to make sure there's nothing going on there, and indeed he has full pain-free range of movement at both hips. But when we look at the knees, we can see that there's clearly a difference in range of movement. He's got full range of pain-free movement at the left knee, but the right knee is stiff and painful. Whilst he has full extension, he's only flexing to 100 degrees. And when you do the movement, you almost feel like the end feel at flexion is quite firm, which is somewhat concerning for this patient. We then go through some special tests like some ACL test, MCL, LCL, PCL. Nothing seems to be shouting out to us. Those tests are all negative. And so that paints quite an interesting picture for this patient. Now is your opportunity to have a look through the case, write down your thoughts, and join us in a second where we'll go through the diagnosis. Okay everyone, time's up. Let's go through what happened with this particular patient. So what we decided, we had an idea in mind regarding diagnosis here, and the first thing we did is actually sent the patient for imaging, both with an X-ray and an MRI scan of the left knee. And the imaging painted a quite specific picture for this patient, which was early osteoarthritis of the lateral right knee. Now, you might be thinking to yourself, well, he's only 35 years old. How can he have developed osteoarthritis this early? Unfortunately, there is some real clues here that indicate to us why this could be. Let's go through it. So the biggest factor in this patient's case was actually what happened 17 years ago. We know that the rate of osteoarthritis of the lateral knee is quicker than the medial knee, particularly when meniscal tissue is removed. Now, of course, our menisci are there to create a cushioning, to create a gap between the joint surfaces. And we need that meniscus. We need it for the whole of our lives in order to maintain the gap between the tibia and the femur of our knee. When patients have removal of large pieces of meniscus early on in life, they lose that cushioning. And for this particular patient, for this to happen at age 18 is pretty young to have a large amount of tissue removed. And as we said, we know that the acceleration of osteoarthritis of the lateral knee is much faster than the medial knee when tissue like that has been removed. This creates a real challenge for surgeons, and we'll go on to this a little bit more in a second. But first of all, we've always got to bear in mind, this is a really good lesson of always asking your patient about any previous knee injuries they've had, because it could well be, as in this case, that it has a large bearing on what's happening in their knee now. So what were some of the particular signs that we saw in this patient that also pointed us in the direction of this early osteoarthritis? First of all, if we look at the subjective history, the fact that he was experiencing early morning joint stiffness that was lasting less than half an hour is quite prominent for osteoarthritis. The fact that his symptoms have been getting worse and therefore his range of movement is such affected. The fact that he has only 100 degrees of flexion is quite noticeable. But what was even more noticeable is the end feel. If you grab your own knee for a second and flex it to the end range, there should be a very soft and elastic end feel, as it is soft tissue structures that should restrict flexion at end range. So when you have flexion and there's more of a firm end feel, that tells us that it may well be joint surfaces or bony surfaces that are restricting further movement. That is not good in a 35-year-old, and that pointed the picture to us that it could be bony surfaces that are preventing movement here in the case of osteoarthritis. We also saw that there was the antalgic gait, the swelling on that side of the knee, and also the fact that it's painful in multiple areas across the joint line. So unfortunately, there was a few things that added up that pointed towards your osteoarthritis. But again, the biggest thing was the removal of the meniscus many years ago. So how do we manage this patient? Let's talk about general options here. First of all, conservative management. We can try physiotherapy, of course, and we can try general exercises to reduce the pain and reduce the irritation to try and improve tolerance. I would imagine that in a patient like this, that would potentially be less fruitful, given the degree of osteoarthritis that he has at such a young age. Remember, he's 35. He's got to try and manage this condition for a long period of time. So then we come to surgical options. And whilst I'm not an orthopedic surgeon, I'm very lucky that I've been able to work with a lot of them. And one key thing that's always been pointed out to me is the removal of meniscal tissue. And as much as possible, orthopedic surgeons look to reduce how much meniscal tissue they remove, and they want to try and repair existing meniscus as much as they can. Keep the meniscus there, because the more that it's there, the longer that it's there, the more it protects the joint. The more you remove and the quicker you remove it, the joint loses that protection, as unfortunately has happened to this patient. So this patient's only 35 years old. They're much too early for a total knee replacement. One particular surgery that might be amenable to them is something like a high tibial osteotomy, which is a particular surgery where they can reposition the tibia or potentially the femur in order to reduce the strain and load going through the lateral side. That surgery is only really designed to last the patient until a little bit older, when they might need to have a total knee replacement. So ultimately, it's a really challenging situation that this patient finds themselves in. And it just goes to show how something that happened 17 years ago can have a big impact on today. So always take stock of your patient's previous knee history. Previous injuries, previous surgeries, previous rehab, it all might change the picture as it did with this particular gentleman. So everyone, I really hope you've enjoyed this case study. If you have, please support us by smashing that like button. It's the number one thing you can do to help us here on our YouTube channel. And if you want more from us on social media, please do check us out on Instagram at Clinical Physio. Give us a follow there. We have loads of brilliant resources for physiotherapists. And if you want more from case studies, we've got a brilliant resource on our membership platform, link in the description below, member.clinicalphysio.com, and that resource is the Case Study Club. There we have loads of brilliant case studies with expert clinicians coming on to talk through their patients, the diagnosis, and all the key factors surrounding their case if case studies is the way you like learning best. So thank you so much for watching. My name's Khalid. See you soon here on Clinical Physio.